Hello, my name is Charles Elliott, and this presentation is titled Clinical Nurse Specialists Disseminating Education to Facilitate Quality Improvement. Now you'll have to excuse me, I've got a really bad case of the man flu, so bear with my voice. So the practicum setting. I did my practicum in a cardiovascular intensive care unit. This CVICU is at a level 1 trauma center, and it is a teaching hospital. With being a teaching hospital, you have residents, fellows, and attending. So it's a 32-bed ICU. They see patients from a vast array of populations, including medically managed cardiac patients, post-op cardiothoracic patients, receiving lung, heart transplants, cabbages, valve replacements, etc. They also employ a numerous amount of devices, including ECOS, balloon pumps, Impellas, ECMO, LVAD, RVAD, CRT, etc. So with that, they can really see any population in the hospital. Now, as far as learning goals, I really wanted to see what the clinical nurse specialist exactly does for bedside nurses and how that intertwines with frontline staff. I wanted to see how she got out there and communicated with the nurses, where she got her information from, and how she implemented her changes. So learning objectives here, we're going to talk about my objectives and how they were completed. So number one, student will learn the role of the clinical nurse specialist. Well, easily enough, I completed that by following her. Number two, student will learn how evidence-based practice is incorporated into bedside care. So anytime that this CNS or clinical nurse specialist would interact with staff, I would usually listen, and if I had any advice, I would throw it in there as well. And when we got back to the office, I would say to her, hey, where did you get that information? How do you come across it? And basically what I found out is that the CNS in this unit is a constant studier. That being said, she is constantly looking at the literature, looking at new and updated evidence-based practice, and she is ferocious and fearless with approaching the bedside nursing staff and the physicians to ensure that our patients are getting the best quality of care. Number three, student will learn how the clinical nurse specialist interacts with staff and disseminates education. So this CNS, she sends a lot of emails. She works with the bedside nurses that have a newsletter and a clinical corner. She ensures that very vital information is disseminated through those portals. There's also a monthly council, a cardiac or CVICU council that she attends, and she ensures information is disseminated there as well. In addition, she will attend meetings with the team leaders and the more veteran nurses to make sure that we are all kind of on the same page, and that when we're educating new nurses, this stuff is disseminated. She meets with the Education Council, who work on new grad nurses and new nurses to the unit. And she goes to the bedside. She states that her office is always open and you can come to her at any time with anything. So reality versus literature. I want to talk about interprofessional teamwork. So I have a quote here. According to Blythe 2011, the Institute of Medicine recommends that nurses should practice to the full extent of their education and training. So we're going to roll into an anecdote here. So in this unit, post-op patients were arriving from the OR, and within hours, they had burns. They had these really strange kind of symmetrical burns that were occurring on the flanks and the armpits, sometimes on a leg, and we weren't really sure why. With working with the OR department, with the physicians, with anesthesiologists, with anesthesia techs, we determined that this was happening due to Bovie pads being placed on the patient with copious amounts of chloroprep for the OR. And what we were able to do is institute ensuring that the ChloraPrep was dried before Bovie pads were placed. And then additionally, bedside nurses would bathe the post-op patient with soap and water as soon as possible to ensure that most of that additional ChloraPrep was washed off the patient and therefore preventing chemical burns. So now we're going to talk about my project. In this cardiac ICU, like I said, they do ECMO. And a lot of times that means going to other ICUs or other units in the hospital and retrieving these patients and placing them on ECMO. So here we have the indications according to ELSO for VV ECMO initiation. Now, basically, without getting into the numbers, what we're saying here is that we want to initiate ECMO when there's a 50% or greater risk of mortality. And we have some numbers here that tell us what exactly defines that. Again, most importantly on this slide here, the best outcome in ECMO for adult respiratory failure occurs when ECMO is instituted early after onset, 1 to 2 days. That's huge. I don't know how many of you work in the ICU, but sometimes it can take a day before we exactly know what's going on with the patient. And then before we actually get the entire team to round on the patient. And basically what I'm getting at here is that the nurse is at the forefront. They see this patient initially, and they often have the most information to provide to the team. Not to mention some additional indications, CO2 retention on mechanical ventilation, severe air leak syndromes, complete cardiac or respiratory collapse, etc. So practicum site implementation. This study right here is very important. So a study conducted by Combs et al. Found that early ECMO intervention in the ARDS population resulted in a 33% mortality rate compared to 49% in the conventional care group. Of note, crossover to ECMO from the conventional care group occurred in 35 patients, resulting in a 57% mortality rate. What does that mean? That means if we get ECMO started early, as opposed to conventional care, less patients die. Also, patients that are left on conventional care and then are brought to the ECMO side of care have a higher mortality rate. Now, it's hard to say if that higher mortality rate is due to not being on ECMO earlier or just the nastiness and progression of the disease. Now, why am I talking about all this? So I kind of spoke with staff RNs and physicians, and I was getting the idea that patients were arriving to the CVICU from other ICUs later than they should be, meaning that we weren't seeing these patients in that 1 to 2 day window. They were coming at 5 days, 6 days, even 7 days. ELSO actually has a relative contraindication to VV ECMO initiation for ARDS if the patient has been on the vent longer than 7 days. There was frustration with the frontline staff members, and there was frustration around the physician saying, hey, I didn't know about this patient until I was consulted on this patient. And by the time we actually got consulted, got the background, got a good HPI, and went and assessed the patient and got him down here and put on ECMO, we're behind the 8 ball. They were really wanting these patients sooner. So what do we do about that? So currently I'm in the works of speaking with the pulmonary ICU, CNS, and some of the pulmonary physicians about the need for expanded bedside RN education. So I want to give them the information about high mortality rates. You saw on earlier slides, the fact that a high PaO2 or a low PaO2 to high FiO2 ratio on the ventilator, if they see these things, if they have a PE, if they have complete respiratory collapse, cardiac collapse, if conventional methods just aren't working on day 1 or day 2, I want the bedside RN to speak up in rounds, and say, hey, is this patient an ECMO candidate? Again, back to my previous slide, nurses should be pushed to utilize the full extent of their knowledge, the full extent. And we are part of the interdisciplinary and interprofessional team. We can do this, and we can save some patients and improve quality of care by getting them started on ECMO sooner. And so to get this done, though, I wanted to be able to just create this piece of education, print it out, go up to the pulmonary ICU and to the other ICUs and say, hey, here, these are the indications that we look at when we put patients on ECMO. If you've got a patient that's like this, go ahead and recommend to your attending or to your fellow, like, hey, we might want to consider ECMO on this patient. I got some pushback. There's a lot of inconsistencies currently in the literature. I know most recently there was a study conducted in the New England Journal of Medicine that suggested that there wasn't too much of a difference between conventional care and VV ECMO care in treatment of ARDS. However, there are still more studies pending, and there are more studies that suggest it is helpful than there are studies that suggest that it is not. That being said, I need to meet with the pulmonary team and see if they are okay with these protocols and if they are on the same page. Because I don't want a nurse going to a physician and saying, hey, I've got a PaO2 of 55 with an FiO2 of 90%. We're considering high-dose steroids and proning. Do we want to start ECMO? And then the attending saying, oh, that's a stupid idea. So I want to make sure the team is on the same page. They're, primarily since it's a teaching hospital, I want them to be okay with the residents and the fellows being approached by nurses with this information saying, hey, should we put this patient on ECMO? And I'm even working with the CNSs about potentially going around the attendings, because if you look at ELSO's guidelines and speaking with the providers that put patients on ECMO, they agree with the criteria. Reflection. So what did I learn here? I have a real fire and a desire to continue bedside RN education. I may actually consider the CNS path. I found it very rewarding. I liked doing the research. I liked speaking with frontline nurses. I liked interdisciplinary communication. Going to those OR nurses, speaking with pulmonary attendings, speaking with ECMO team members, trying to figure out the best course of action based on the literature to provide quality of care. That was something that was very gratifying to me. So ECMO and the uncertainty moving forward. What I'm saying here is that ECMO's kind of newer. We did this on babies and peds patients for a very long time, and the ECMO adult population is really exploding currently. I know at the facility I've been at, our cases, our runs being patients put on ECMO have been growing. I wouldn't want to say exponentially, but basically doubling every year. Most recently, they have implemented a transport program that actually goes to outside hospitals, cannulates the patients, and brings them to this institution, or they'll go get them, bring them to the institution, and cannulate them. And they're working with outreach programs for that. So what is the future of ECMO as a nurse? I think there's a lot of education that is lacking for the bedside nurse in terms of ECMO. I want nurses to be educated in this device, in its indications, and knowing when their patient is a candidate. Currently, most physicians only learn about ECMO through their fellowship or their residency. So there's clearly a lot of education that's lacking. And I think that moving forward, I would like to see ECMO introduced to new grad nurses across the board, and so that they know that this tool is ready and available for their patient depending on what is happening. Thank you for listening. I hope I wasn't too boring and that my man cold doesn't